All right, thank you so much for having me. I was asked to talk about real-world experience with FFR. And so I think it's really hard to talk about FFR without talking about the non-hyperemic pressure ratios. So I'm going to be talking about both of them through physiology. So these are my quick disclosures, mainly that Abbott was kind enough to support me to be here. So what we know about the coronary circulation is that the angiogram only shows about 5% of the actual coronary tree. The vast majority is not seen because it resides in the microcirculation. So angiography as a whole does a poor job of actually delineating the true extent of disease that a patient can have. So there's certain things about the coronary tree that are important to know because foundation of how we do our invasive physiology is predicated on the fact that pressure is consistent or should be consistent throughout the entire coronary tree. So as we know, as the vessel begins to gradually taper, the diameter gets smaller and smaller. At the same time, the cross-sectional area obviously gets smaller as well. But the resistance actually goes up while flow goes down. So the relationship between flow and resistance allows pressure to be exactly the same through and through. Now, if you have a stenosis, what happens is that the flow is altered such that the pressure is now different in the distal portion of the vessel compared to the proximal portion of that vessel. So we can do a ratio looking at the pressure proximally to distally and then subsequently get our fractional flow reserve. Now, the issue with fractional flow reserve is that you really need to make sure that the vessel is maximally vasodilated. So you give a hyperemic agent. So adenosine is the most commonly used agent, as we know. It's given both IV and IC. There are issues to IC compared to IV, but there's also benefits. Nevertheless, a lot of the actual flow is contingent, the FFR amount is contingent upon the size of perfusion. So if you have a large amount of myocardium that's being supplied by a vessel, a stenosis will most likely potentially be positive. But if the part being supplied has some dead tissue or is very small, specifically distal in the actual vessel, then it's possible that the FFR may be negative or borderline. Now, the other part about FFR is that it actually accounts for collateral circulation. So if you have poorly developed collaterals, the FFR can be positive, but once there's much better collateralization, the FFR can be negative, okay? So the validation of FFR really comes from the FAME trial, FAME1 and FAME2. So FAME1 basically found that if you use FFR-guided PCI in a randomized fashion compared to angiography alone, that you actually had an improvement in survival from MACE. And then FAME2, what it looked at is it looked at patients in whom all stenosis had an FFR of more than 0.8, were entered into a registry and received the best available medical therapy, and then those that had less 0.8 or less were treated, compared to those that just were treated with medical therapy, and found that there was a marked reduction in MACE rates. Now, if you look at the totality of data for FFR, not just from the FAME studies, what it shows is that you have a decrease in cardiac death or MI, cardiac death or MI, all-cause death or MI, and particularly MI. So the difference that you derive, the benefit that's derived from FFR is really from MI. It's not cardiac death necessarily, that hasn't been borne out in the literature, nor all-cause mortality. So it's actually MI, both spontaneous MIs that you prevent by treating when it's appropriate, and periprocedural MIs that you defer by not treating. Now, with the use of FFR, you have to use a hyperemic agent, and the problem with hyperemic agents are manyfold. But since then, we've now developed a way of looking at a specific portion of diastole called the wave-free period. And what we can do is not have to give a hyperemic agent and still get our pressure assessments, both distally and proximally, and use that to figure out whether or not a patient should be treated. So Phillips was responsible for the first non-hyperemic pressure ratio, IFR. And so again, it looks at a portion during the wave-free period and during diastole to calculate this. And no hyperemic agent is needed because it's during diastole, so the vessel should be maximally dilated and the resistance should be naturally constant. Now, the data around this, so there's fairly robust clinical data, both from the defined flare and the sweetheart studies. So nearly 4,500 patients have been randomized in these trials. And when you compared FFR to IFR, there was no statistical significance in terms of outcomes. So they're fairly similar. The other part are the limitations of FFR compared to the non-hyperemic pressure ratios. So we know that when we give adenosine and other vasodilators, patients can have profound discomfort. They can feel flushing, they can feel like the world is ending essentially. Moreover, it requires time to give these medications, wait for the hyperemia, and then to get your value. And then there's also an associated cost because you have to give drugs, you have to wait, which can also impact lab throughput. Whereas the use of non-hyperemic pressure ratios offsets that. So the more myocardium is being subtended. So what you really want to do is you want to stent from 1 to 2 and take care of that, and you can leave 3 alone because you're not really going to alter the pressure. So that's something that you can use your non-hyperemic pressure ratios to help decide. The other difference between FFR and IFR is in terms of crosstalk. So if you have 2 lesions that are tandem, what happens is that the first lesion, the one that's closest, is actually underestimated, and the one that's distal is overestimated. But if you use the non-hyperemic pressure ratios, they're all independent and they don't have the crosstalk. So therefore, you can use that pullback to decide where you need to treat and how you need to treat. Moreover, you can figure out what the best treatment modality is. So take a look at these 2 pullbacks. One of the things you may realize here is that there is a diffuse loss of pressure because there's diffuse atheroma. Whereas here, you have a big pressure loss at a focal area. So the pullback on the right would be well treated with a single stent, whereas the pullback on the left most likely would be better treated with a LEMA if this was an LAD. Now, the other thing that you need to know is that while you can use invasive physiology to determine whether we need to treat or not and where to treat, you can also figure out if you did a good job with your stenting procedure. So from defined PCI, what they found was that if we did a IFR at the end of the PCI, approximately 1 in 4 patients left with residual ischemia that was still in the positive threshold. And the part that's even more interesting is that nearly 80% of those patients, all you needed to do was do a bigger balloon inflation or just put a second stent in. So I'll stop there in the interest of time. Again, physiology really helps determine whether we need to treat or not, how to treat, and if we've done a great job. And the non-hyperemic pressure indices may provide some additional benefits over traditional FFR. Thank you so much.
Thank you, Darshan, for a wonderful presentation. Just really loved it. So I have one question to you. Suppose you have serial lesions, and the proximal lesion is very tight. So there's a pressure drop between the proximal segment and the mid segment. So the pressure is already low. To pick up the distal pullback on the pullback, so you have a very low gradient. Suppose the pressure is 100 and now the pressure drop goes to 60 in the mid part. Now you have very little avenue for another pressure drop on the second lesion. So wouldn't you like to stent the first one and then come back to look at the second one?
Yeah, but, so again, if you look at the data and the people that are more comfortable or very knowledgeable with the non-hyperemic pressure ratio state that there really is no crosstalk between the 2 lesions. So if you use FFR, then the answer is yes. You probably need to treat the proximal to figure out how severe the second one is. And usually what ends up happening is that the proximal is underestimated whereas the distal is overestimated. But if you use the non-hyperemic pressure ratios, it should not make any difference.
Yes, as you said, there are advantages and disadvantages of non-hyperemic pressure ratio. And
it's fairly controversial
how to differentiate to use in your daily clinical practice?
Yeah, so my daily practice, the way I do it is, so technically FFR is the gold standard, and the non-hyperemic pressure ratios can be utilized. And so the way I use it is if the non-hyperemic ratio is definitively positive or negative, so and it's not in the gray zone, so if it's not 0.87 to 0.93, and I know it's very positive or very negative, then I go with that value and use that. If it's within that gray zone, so if you looked at the Syntax 2 trial, it necessitated that you would potentially use FFR at that time and use that as the final arbiter of whether it's positive or not.
So thank you, Darshan. You could join us on
not a problem. Glad to do it.